All right, we are recording.
Hey guys, thanks for tuning into Straight to the Core, an in-depth, no-nonsense look at all things physical therapy, wellness, and the business of being healthy. We are your hosts. I'm Claire. I am Mark's wife.
And I'm Mark. I'm Claire's husband.
Today, we are doing a little two-part series. The second time around, because we've already recorded this once and had a little technical difficulty. So
yeah, it was a giant waste of time.
It wasn't. Oh, yeah.
Yeah, it was.
It was, yeah. Today we're talking about ACLs, and this is a big topic, so we didn't want to overwhelm anybody because I know a lot of people have questions about this, and when they know somebody that gets injured or they have an injury themselves or a family member has an injury, so we're going to try to cover a lot of the topics that have to do with ACLs, but not overwhelm you guys. So we're breaking it up into two parts.
Yeah, two-part episode. One will be talking about what the ACL does and how it's repaired, and then the rehab portion will be the second portion.
Yes.
All right, so what is the ACL?
What is the ACL, Mark?
The ACL, as per Claire, is the seatbelt of the knee.
It is. I say that a lot, actually.
And it's actually pretty true. You can drive without a seatbelt, but if you have an accident, you're going to want your seatbelt. So why is it important, and what does it do?
So your ACL is a ligament that is on the inside of the knee, so you cannot palpate it from the outside, and it helps to control hyperextension. It helps to control lateral and pivoting stability of the knee. The A stands for anterior.
Its attachment onto the tibia is the anterior portion, so it goes from the posterior lateral corner of the femur,
or the upper part, your thigh bone, basically.
Yeah, and the anterior medial portion of the tibia.
Or the front or the front inside area of the tibia, which is the bigger of your two lower leg. So essentially, if your foot is planted, it stops that lower portion of your leg from continuing to move forward, which is how a lot of people end up tearing it. It also helps to control, like I said, hyperextension, or how, like, kind of bending your knee backwards. Rotation. Yeah.
Yeah, well, it's important because it actually kind of protects the meniscus, which is a lot harder to repair.
So when I talk about it's the seatbelt, quote unquote, of your knee, essentially when you tap on your brakes lightly in your car, it's not like your seatbelt locks up. You rely on the muscles of your trunk, of your core, your abs, your lower back kicking in to help stabilize you. So tapping lightly on the brakes, you don't use your seatbelt. It's when you have to slam on your brakes or you make a very quick jerk of your car that seatbelt has to lock in and help hold you in place, because the force of or the speed of your movement is too much for just your muscles to maintain. That's what your ACL does. So basically that ACL is kicking in to help stabilize your knee or that knee joint when the forces or the speed of your movement overcome that.
And it can hold up to 500 pounds of tensile force tested in a lab.
She's strong. Yeah.
That's a lot, although triple body weight cutting and pivoting, quadruple body weight cutting and pivoting on a turf surface, it's a lot of force.
Right. Well, and Mark said tensile strength. So basically how much weight can it hold coming straight down, essentially?
But it's not dropping it. It's just tensile.
And that's not where most ACL tears happen. No. It's just through tensile strength. That would be impressive.
Wait. I've never seen that.
I haven't either.
Isometric tear? Yeah, it's not. I don't know that it's possible.
ACLs get torn through.
Yeah, how does that happen? Okay.
Yeah. So probably the classic non-contact, and we'll get into that.
And 70% of all ACL tears are non-contact. Right. So there's this misconception that you have to get hit. Predominantly, most of them involve zero contact.
Correct. And especially in females.
Correct.
So a non-contact ACL means that there's no contact, right? Like
no outside force.
Right. It's not another football player hitting the knee with a helmet. It's not another, soccer player running into your knee. It is purely from non-coordinated movement of what the rest of your body is doing in terms of what your knee is doing. So your knee's going one direction, the rest of your body ends up going a different direction.
An important caveat here. So I think most people would agree that the non-contact ACLs are very somewhat preventable, because that's your muscular system and your balance and proprioception and the biomechanics of a landing or pivoting and cutting are affected and are not effective in protecting the ACL. If you have a contact injury, that's a totally different situation. You can't really condition your body to absorb a car accident. It's not really possible. But the non-contact are preventable.
Well, to some extent, obviously.
Correct.
And there's kind of off on a tangent, but females tend to tear their ACLs 4 to 8 times more likely than their male counterparts in the exact same sport.
Good job, ladies.
Thank you. We'll get back to that here in just a second because there's a number of reasons why we think that happens, and some of them are controllable and some of them are not, potentially.
Correct.
But in general, your caveat is correct that non-contact ACLs, I mean, if it's going to happen, it's going to happen. It's one of those fluke things. I mean, take football, classic example. You can't necessarily control if another player is going to hit you in the knee because it's the nature of the sport.
Correct.
So non-contact ACLs are somewhat preventable in the sense of body awareness, proprioception, which is a fancy term for body awareness, balance, control, eccentric absorption of force, those sorts of things. But there are some other factors that we don't necessarily know if we can control.
What does eccentric mean other than your closet? Eccentric.
That's
different.
Yeah. That's like, my closet's not eccentric. That's
Eccentric.
Like, yeah. It's not.
Similar.
Anyway.
Okay. We digress.
Eccentric would be deceleration, or essentially you are trying to control a movement while slowing it down, or I suppose a good example of that would be if you were jumping. Do you fall very, very quickly, or are you able to slow or decelerate that movement by absorbing the impact using your muscles? Eccentric, technically, when it comes to a muscular sense, means that the muscle is lengthening
under pressure, yes.
Which
is more stressful.
Yeah. It's a harder contraction. If you've ever done an eccentric workout, it's usually low load, but prolonged contraction time or time under tension.
And it is responsible for delayed onset muscle soreness, primarily.
Most of it.
Interesting.
Yes. Okay, so females tear their ACLs 4 to 8 times more likely than their male counterparts in the same sport. So obviously there are some sports that seem like the ACL tears are much more common. Football, obviously. Soccer, big one there. Cheerleading / gymnastics for females.
Skiing.
Mm-hmm. High velocity. Yep.
Yeah.
Yep. So why do females tear their ACLs so much?
Well, there's a multitude of factors for the body type and body frame, and the frame size. They have wider hips than men, and so the muscles are not built necessarily in a straight line. There is an angle called the Q angle.
Correct. So basically, and this is why we kind of see a little bit of an uptick with puberty, is that women's hips spread out, or not our hips necessarily, but the pelvis spreads out to prepare for childbirth.
Yeah.
So the pelvis spreads out, which means that your hips spread out. You have something that's called a Q angle, which is essentially the outside of your hip down to your kneecap down to your patellar tendon, tibial tuberosity, where it attaches. And so women have a greater Q angle than men do. Essentially, men are built more, as Mark said, straight up and down. Women have this little angle. And so what that means is that we have the tendency to allow our knees to get into what's called a valgus position. Or if you draw a straight line from your hip down to your foot, the knee tends to be on the inside of that line.
Correct.
That's one factor. Now, obviously, you can't control that. You can't say, sorry, ma'am, you were a really good athlete, and then you went through puberty and your hips spread out, and now you're no longer safe to play sports. So that's kind of one of those things that we try to control it as much as we can. We do, back in the day, it was sports metrics, which is that still a thing?
I don't know.
But it's body awareness. It's single and balance. It is, like jump training. We do know, at least from a rehab standpoint, is that if you land with more of a stiff leg, so decreased knee flexion with jumping tends to lend itself to a higher risk of either tearing or re-tearing. So that's one of those things, jump training, female training, things like that.
That's that eccentric loading we were talking about before.
Exactly.
And then proper alignment on the deceleration force.
Right.
Yes.
Not just having them jump, but are they controlling the knee by controlling the hip?
Yeah, it's jumping correctly. It's just running. Do they run correctly? Do they jump correctly?
Right. Now that leads me into my next point, is that for a long time, and I think it's probably still a factor, is that one of the reasons that we thought that females tore their ACLs more than males is what we call the training effect, is that we just trained men and boys different than we trained females. For the longest time, strength training was not really hugely pushed for female sports as much as it was for male sports.
Yeah.
I can remember.
I feel like it's fairly changed now.
Yes. Yeah.
Maybe not equal, but it's changed.
When I was in high school, for some reason, I ran track and cross country, and for some reason, the only lifting we ever did in the weight room was we benched.
Okay.
No idea why. I have no idea. We benched. That was it.
There is not good carryover there.
No, not a lot. But now I think, as Mark said, and I agree with that, it has changed slightly. And so we do have that push for females to be lifting. But in that caveat as well, then women tend to not have as much hamstring strength compared to their quad strength. Women tend to be a little bit more quad dominant. I can attest to that. Men tend to be a little bit more hamstring glute dominant. And we probably should have led with this in the beginning. Your hamstring basically doubles down on what your ACL does. So your hamstring with its attachment, since it attaches on the backside of that knee and the backside of your tibia, it helps to counteract, or it helps to create the same force essentially that your ACL would do in terms of stabilizing your tibia and not letting your tibia shove forward, which is what your ACL does.
Yeah, one place that we have a problem is the supervised weightlifting for women. So because women have that wider Q angle on average, they're going to need more instruction on how to squat and deadlift properly, because they're going to have the tendency to
say it with your whole chest, Mark.
Okay. Anyway, so it's going to be more difficult for a female that's built with wide hips to learn how to squat, because they have a disadvantage mechanically. So they're going to need more assistance in the coaching aspect. And sometimes we don't see a lot of supervision or coaching in the weight room, men or women.
Right.
They're just in there working out.
Across the board, whether it's, school or some of the adjunct places that offer strength and conditioning for whole teams, which I think that's obviously a step in the right direction. But at the same time, you have 15, 20 girls all squatting, all doing, weight training, deadlifting, things like that. It's almost impossible to make sure that every single female is avoiding some of those more dangerous positions.
Tough. Yeah. Other factors are hormones.
Yep.
Obviously, that is responsible in a lot of ways for the hip widening anyway, but hormones and different types of cycles, timing, it affects women. We don't know that how much. You may never know that, but it is a correlation.
We tend to find out that information more anecdotally, whereas a female will say, oh, yeah, now that you mention it, like when I tore my ACL, I had my period that week, or something like that. Now, there are obviously hormone fluctuations that do specific things in the body. And so one of the hormones that we see kind of fluctuate just in puberty in general allows a little bit more flexibility in tendons and ligaments.
More play in the system.
Yeah. So, but again, I kind of chalk that up as to one of those things where it's like, okay, that's an interesting thing, but what are we going to do about it?
We can't control that.
You're not going to sit there and tell a female athlete, regardless of what her age is, hey, sorry, for 1 month out of your 1 week out of each month, you're not playing sports.
Yeah. So, they also have a smaller intercondylar notch.
You do. Yes. Yes. Women are just built differently from a skeletal system. And in terms of where the ACL is running on the inside of the knee, sometimes there's not a lot of space there.
Yeah.
And just because we're smaller framed. So that can be one of those things that, again, you kind of chalk it up as to saying, okay, well, what am I going to do about that? But then hopefully if there's a good surgeon involved with them and they go in, then they're taking those things into consideration when they're doing the reconstruction, because they'll
give you some more space.
Yeah, they're trying to prevent that from happening again.
Yeah. Yeah, and that would go right into re-tear rates. Re-tear rates are pretty low if you rehab correctly.
Yeah. Statistically speaking,
there are 400,000 ACL surgeries performed per year.
Yes.
It's a lot.
6 months after ACL reconstruction, and we'll talk more about the rehab portion of it in our next podcast, but 6 months, your graft strength is only about 50%. So what we've learned here is that as you rehab, it used to be, how quick can I get back? And now we've kind of gone back and overcorrected, I think in the correct way, that holding off a little bit longer, that's the number one predictor of a re-tear rate, honestly. Like men,
time.
Female is just time. It's the longer amount of time since you've had rehab or since you tore it, then that decreases your risk before going back into your competitive sport of choice.
Yes, I have a very interesting group of statistics there.
Please.
You are 51% less likely to re-tear every month after 6 until 9 or 10. And then it goes down pretty quickly there. Mm-hmm. So 9 is kind of a better number, although I think it's more criteria-based, not just time-based. Time is your speed limit, but it shouldn't be your only criteria. Some people are not doing perfectly well at 9 months.
Correct.
As far as mechanics and strength.
Yes.
So the balance between hamstring and quadricep, knee control, hip control, proprioceptive awareness, and then trusting that limb. A lot of it's just a trust issue.
Yeah. So how do you, if you're listening or you're watching and you don't necessarily know, how do you tear your ACL? Like we kind of talked about the obvious ones, right? Like helmet to the knee.
Honestly, one of the most common ways is an awkward pivot and cut on a sprint. That's why we see it in soccer. We'll see an awkward cut and a pivot, and then the leg doesn't have any room to give. And then also turf has a 1.6 times more likely, especially for women, increased tear rate. So turf is somewhat responsible for increasing the risk for women as well. Men, to a lesser degree, I don't know why that is, but that is what the study says.
Well, yeah, probably. I mean, I would agree. The pivoting, the quick movements, the reactionary
The single leg pivoting movements.
where you're kind of planting, and like I said earlier, your body goes one direction, but your knee kind of goes the opposite direction, or doesn't move when your body does.
And you see less of them in basketball than soccer. And there's a lot of cutting, running, and jumping in basketball, but it's not quite the same high velocity. And
I think it tends, especially in female basketball ACL tears, it tends to be on a jump, a rebound, something like that.
Awkward landing.
Yeah, less with the pivoting. So I think that maybe not necessarily turf versus grass, but just the stickiness of, where the pivoting is happening.
surface.
Yeah.
Side note,
Please.
this is important. So prevention is obviously important for, a lot of people. And in the weight room, obviously very important for strengthening and prevention. I have never seen anyone ever tear an ACL lifting weights. Ever.
I have one.
Who? How?
Yeah, my high school football player, he was doing a lunge. He was doing a lateral lunge. And it's kind of a spaz anyway, but.
That is super uncommon.
Yeah. But
That thing was
it was a non-contact, did kind of a valgus position when he was doing a lateral lunge.
guessing it was torn before. Or somewhat torn before.
That's just an example of probably poor proprioception.
Probably.
But,
It's you're not going to get it from squatting.
Nope.
No.
Probably not. I mean, there's disastrous things that can happen, but
it's rare.
I think there is that common misconception that people are, if I do X, Y, and Z, like I'm going to hurt my knees. And there's plenty of knee injuries that can happen when you're squatting or doing a leg press or deadlifting, but your ACL is not really high up on that list. It's possible. There's always weirdo things that happen, but
yeah, usually because of horseplay or something in the gym.
yeah. Well, lastly, before we jump into the rehab portion of it, then, okay, so you've torn your ACL. What happens then?
Yeah, what do you do?
Yeah. Well, I probably should back up slightly. You have an injury that you suspect is an ACL. We can do an on-the-field assessment where you can kind of, try to tug on things a little bit and see, okay, is there too much movement there? Is something moving that's not supposed to be? And those are great. Athletic trainers are great at that. Sports physical therapists are great at that on-the-field assessment. And then some people, you don't respond well with an on-the-field assessment, and you have to get that MRI. I mean, orthopedic surgeons, obviously, like in office, they
want those, yes.
Yeah, can get their hands on something and be like, well, I'm pretty sure this is what we're looking at. But then you go into an MRI, and it's an MRI diagnosis, and you can have an ACL in isolation, and you can have an ACL with a whole bunch of other things.
With a bunch of friends.
Yeah.
I will say, though, only 10%. The last study that I read, 10% ACLs are isolated to just the ACL. So those are very common. So there's other structures involved generally.
Right. So you can have your medial and lateral meniscus, which are like little donuts of cartilage that help shock absorption in your knee.
The MCL, which is actually connected to the medial meniscus.
Right. So you can have something that's called an unhappy triad or a terrible triad, which tends to happen more with women. And it's an ACL tear with a medial meniscus tear and an MCL involvement of some sort, sprain, tear.
Yep. I've got one starting next week.
Mm-hmm. And I think going back to that Q angle, that's why we see a little bit more of the MCL, medial meniscus, ACL tears in women, just because of that valgus force. As we get better at diagnostic imaging, I think we pick up more and more of that. And then as we look at the literature as to who's doing well post rehab and who's not, then I think we've also figured out that while you're in there, like obviously you don't want to do anything that's unneeded, but if you can take care of things like a meniscus tear, if you can let that MCL scar down before having surgery, then people do a lot better than just going in and being like, all right, well, this is the biggest thing. Let's fix that. We'll deal with anything else later.
In the old days, it was very common that you have a Friday night ACL tear, you're in surgery Monday morning. And now we don't see that as much. It's pretty common now to do a 4 to 6 week pre-rehab.
Right.
To get your
Prehab.
range of motion, get your quad to fire again, get the swelling down. A lot of the research in the surgeries are the outcomes are just much better if you have everything good going in.
Right.
And I usually warn my people, if you do the prehab correctly, you'll wonder why you're having the surgery.
Right before surgery, you'll feel...
Oh, I feel great until you turn and pivot.
I do have one gal who ended up, and it was through no fault of her own, I don't think, but her prehab was not, I didn't do her prehab, but her prehab was a little probably rushed. She went into surgery without full extension, without full flexion. Yeah. I ended up doing her rehab afterwards, and man, we fought tooth and nail for both of those motions. And she admits, she's like, yeah, it didn't bend all the way, and it definitely didn't straighten all the way going in. And that's
a problem.
Yeah. Not a surgeon that we see a lot of patients from. I will say we are lucky enough to work with a lot of really fantastic surgeons, ortho surgeons that do ACLs and that kind of specialize in sports. And so this was kind of a one-off in the sense that...
Yeah, it's pretty rare.
Yeah. The vast majority of surgeons that we work with are really good at saying, okay, like we're going to tentatively set this date for surgery, but if you don't meet these requirements, then we're not doing it.
I like that. I've seen better outcomes and rehab in that first month, much easier.
Agreed. Well, and I think too, as diagnostic imaging gets better and we pick up on things on MRIs, then you can have something like a bone contusion, which is basically like a bone bruise. And we know you don't want to operate on a hot joint. So pushing that surgery out, as detrimental, or not as detrimental, as I guess emotionally upsetting it is to patients sometimes to have that lag time where they're like, I'm just waiting to get
back.
better.
To go back.
Then we know that if you can get that bone contusion to basically calm down, to heal, and to be in a better position going into surgery, then they do better afterwards.
Yeah. And I think if people forget sometimes that your body doesn't know the difference between an injury on the field and an injury in a surgical
I have shorts.
Sweet. Great.
It's a squirt, you guys. It's a squirt.
It's a lot of leg this morning. It's like sexy ACL.
Interesting.
For your viewers on YouTube.
It's a squirt.
Anyhow. But yes, I think it's important to remember all of those things.
Yeah. But it is...
graft type. We have to talk about that real quick.
Yes.
There's multiple types of grafts. It was very uncommon, but early in my career, we saw Achilles tendon grafts. We saw Gore-Tex, all that kind of grafting procedure. Nobody does that anymore.
Graft is essentially what you're replacing the torn ACL with. And I guess ACL reconstruction is a little bit of a misnomer because it's actually a replacement. I mean, you're not repairing the ACL, except
there is one that, who does that,
who's kind of doing something new, and
which is
it's
fantastic.
Very cool. Yeah. But essentially, your graft type is you're taking something from another part of a body.
Usually yours.
Yes, whether that's yours or somebody else's. And you are basically making a new ACL. You're taking out the old one, and there is, I think people forget about that sometimes, is that you're taking out the torn part, and that's where a really skilled surgeon, if it's needed, can go in and say, all right, small intercondylar notch. Let's create a little bit more space.
Give it some space,
yeah. But you can have a quad tendon repair.
Much more common now.
Yep. You can have a patellar tendon repair.
Still common.
Yep. You can have a hamstring repair.
Less common than it used to be.
Yeah, but it had its moment.
I mean, they're still effective.
Yeah, because it is a double bundle. And there's some limitations with every graft type. And then you can have a cadaveric or a donor, essentially.
Which has the highest rate, but not huge rate of retear. But sometimes it doesn't revascularize. And I think it's important to note, all of these grafts that we're talking about, they're all different in the etiology of the physiology of what's happening. So if you have a hamstring graft, you're taking out part of a tendon.
Yeah, there's pros and cons too.
Yeah, you're taking out part of a tendon and asking it to be a ligament, and those structures are really not that related. So your body has to create an environment that it heals but assimilates into a ligament, and it's called
ligamentization.
Yes, taking a graft and turning it into a ligament is called ligamentization.
Yes,
it's hard to say,
and it is it's good to note that when people are like, what's the best graft type? There's so many factors that come into play. I'm short. I might not necessarily be a candidate for a hamstring graft because my hamstring tendons might not be that long
enough.
Yeah. I might not have long tendons in general, regardless of height. I mean, you can have a low insertion of a muscle that's just how anatomically you're built. You don't have control over that. And it might be one of those things that the surgeon's like, ooh, you know what? Like that was plan A. We got in there, didn't like it. We went to plan B.
Yeah. And it's important to remember some of the newer grafts and this type of grafts are great and fantastic, but one of the best grafts is whatever your fantastic surgeon is used to doing. If there's a new procedure out there and you're like, I want the new procedure, even if that procedure may be a little bit better than the old one, the new guy doing the new procedure is not going to be doing 1,000 of those like the old guy with the old procedure, as long as it's still a relevant procedure. So whatever your surgeon is doing, as long as it's a great reputable surgeon, is still the best for you. They're not going to do something to you because they care about your re-tear rates as well.
Absolutely. And I mean, you see it all over. People are on the internet and they're like, what's the best graft type? And then you have everybody chiming in. There might be a very specific reason that their surgeon chose that graft type or that your surgeon chooses a different graft type.
Correct.
So talk to your surgeon about that. There are some very weird things that happened early in our careers that we used to do a contralateral hamstring.
Terrible idea.
So yeah, let's create another injury on the opposite leg to take a hamstring from there. Yeah. We definitely got away from that very, very quickly.
Which is good because you're actually more likely to tear your other side than the surgical side as long as you rehab correctly, which is a huge asterisk.
Yes.
Huge.
Yes.
Proper rehab is extremely vital. We'll talk about that later.
Yes.
But
and there's now there's a different technique that basically also helps to kind of shore up that posterior lateral corner that a couple of surgeons here in town are doing. I think it's called LTAC, something like that. LTAH, I think maybe. That basically you're helping to give more stability in your knee, even though you're going in and repairing something that is improving the stability of your knee. So it's kind of, you're doubling down on helping to control the knee. And there's a couple of surgeons, like I said, here in Omaha that are doing that now. Very cool.
Yeah.
We're on the forefront. But yeah, so quad tendon graft and patellar tendon grafts are probably having a little more of a trend in terms of what we see.
Yeah, at least in Omaha.
Yeah. There's pros and cons, like I said, to each of them. Patellar tendon is one of those things that it was in favor, it went away for a while, or you didn't see it as much, and then now it came back just because it's a bone graft. So you take a chunk of bone on either end, and basically from your tibia tuberosity and your patella, and then you have that patellar tendon in between, and then going in and drilling that bone into other bone heals at a very predictable rate. So you're not really disconnecting anything.
Yeah.
So that had its moment.
Plus the patellar tendon technically is a ligament.
Wow. And
which is the only one that's actually a ligament.
And it's very used to tensile strength
Correct.
as well. We got away from it, especially where females, you had a lot of anterior knee pain with that. But again, pros and cons to each of them. Hamstring grafts, sometimes you have hamstring graft pain. I mean, they don't really
and you don't
repair that graft site. You just kind of let things
and then you have
down.
an inherent weakness, so you have to get it stronger than it was before because you've taken portion of that out. And
right.
As we talked about earlier, the hamstring is kind of like the next door neighbor, good buddy of the ACL.
Right.
It helps it.
Right.
It does what it can't do and vice versa.
So then there's that thought of, you're taking away something that is specifically meant to help protect the ACL.
Correct.
And vice versa. So there's that factor as well. Quad tendon grafts kind of having its moment right now.
It is very popular.
Trendy.
They seem to do really well.
Mm-hmm. And big push, obviously, to get some knee flexion there in the rehab portion. Then we'll get more into that here in part 2.
Yeah.
But, like I said, there's pros and cons to each graft type. So talk to your surgeon about that. Talk to your therapist about that.
And make sure you have a really good surgeon.
Yeah. It's okay to surgeon shop.
Yeah. I mean, if you were going to have somebody build you a car or do brain surgery or build you a house, you're not going to just take any Joe Schmo off the street.
The first one who can get you in on the schedule.
Oh, yeah. I got an opening tomorrow. Why do you have an opening tomorrow?
Right. Unless it's November, December, in which case surgeons are like, yeah, whatever, just tack them onto my schedule.
Yeah, of course.
So that is kind of ACL injury in a nutshell. We're going to get into, on part 2, everything rehab related.
Rehab.
Shot for your surgeons, shot for your PTs as well.
Yeah.
But I think probably what we should have led with, but definitely we'll end with here on this first part, is that ACL used to be a career-ending injury, right? You tore an ACL in soccer, baseball, football, like that was it. Oh my gosh, how tragic, you're never playing again. And that's just not the case anymore.
Yeah, you have college athletes, you have high school athletes, you have pro athletes. They go back and have very long careers afterwards. So this is not a career ender, it's a career annoyance.
Right.
But sometimes it allows an athlete to address the weaknesses that got him in the predicament anyway. And
Absolutely.
so they can actually come back better and stronger by working on those weaknesses because you have built-in recovery and accessory time.
Absolutely.
Yeah, so it's not necessarily a negative. It can come at a negative time,
right.
but there's a positive spin on.
There can be, absolutely.
Yes.
Yep. And just the same way that the surgeon is very important, obviously, and you need a skilled surgeon who's awesome at doing, that specific type of injury, whatever it is, isolated ACL or ACL with some other friends in there, then the rehab portion of it is just as important. And we'll get into that
Next.
Stay tuned.
All right.
So, as always, if you guys have any questions, if this brought up some PTSD or you're still having some issues with your knee or you're a fresh knee injury.
Yeah, or your ACL rehab didn't go so well and you don't trust it.
Right. Reach out. We're coreomaha.com. We are on Facebook. We're Core Physical Therapy and Sports Performance. And Instagram, we're Core Omaha.
YouTube.
Yep, YouTube. We have a Twitter, but nobody.
I don't update it, sorry.
I know, sorry. Don't tweet at us because we won't
No
respond.
TikTok either. I just don't have time
No,
for that.
absolutely don't TikTok us. But I'm Claire.
I'm Mark.
We're out.
Peace.
Yeah. Please do.